Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Immunotherapy is revolutionizing cancer care, and we have brought you several stories about one particular kind of immunotherapy called CAR T cell therapy. That's when your own immune cells are drawn from your body, then taken to a lab, genetically engineered to fight cancer, and then given back to you. We've been sharing CAR T success stories for a couple of years now, but today we're meeting a man whose cells were taken to a lab only for the genetic engineering to fail. Now that rarely happens, but when it does, what happens next? To answer that question, we are talking today with Todd Wiseman. Todd was treated for lymphoma back in 2020. Todd, good to have you. How are you feeling today?
I feel like maybe $2.5 million.
I like that.
I don't know the number, but
that's a good high number, so pretty darn good.
Feeling great.
Good. Well, we're so glad to have you with us to share your story. Also with us is hematologist and oncologist Dr. Nashin Ahmed. Dr. Ahmed is the Assistant Director of Cellular Therapeutics and the Medical Director of Blood and Marrow Transplant Survivorship at the University of Kansas Cancer Center. So thank you for bringing Todd's story to the forefront. I'm glad to have you.
Thank you.
How often do you guys see each other? When's the last time you guys got together?
It's been too long.
Too long?
Ironically, yeah. I mean, I felt like these people were my family. I saw them a lot.
Good.
And haven't quite known what to do without seeing them every week or two.
You create this bond, and then you're like, where'd you go?
Yeah.
So it's kind of nice to come back together, right?
Exactly. So I remember distinctly 2 months ago, but it does feel like too long.
Too long. Okay. Well, we're glad to have you both here with us today. And before we talk about CAR T, let's go back to this original diagnosis, Todd. How did you find out that you had lymphoma?
Well, I came to a meeting I had with Ashley Goff and Dr. Jody Olson for another condition I had been dealing with, and my wife and mother-in-law and sister-in-law had all told me, you don't look so good. So, and I remember Carla that's my wife, she was mad at me because you've got insurance, we need to take care of yourself.
Go get checked out.
So we came for that meeting, and I can remember Ashley looking at me with the full of compassion and sadness. I looked like, man, I'm in trouble. It's kind of, so we noticed the blood work was really bad at that point, and then over a course of a couple weeks or so, that was at the end of February, or sorry, that was 2022, Thanksgiving-ish, Christmas-ish, and then about the first of the year after the bone marrow biopsy, I had, we discovered the actual lymphoma.
What was that day like for you and your family?
Stage 4.
Stage 4?
Yeah. So something that I have been aware of is feeling good and not knowing you feel good, or not feeling good but not realizing it, and paying attention to one's body and health. And to jump ahead real quick, that's been part of the exciting part of this process, is I could feel myself coming back, and almost like being cognizant enough to witness your own creation, so to speak, and feel what that's like. And I was not attending to that before at all.
Well, yeah, you sometimes you don't know how sick you are until you start feeling better. And go back to that when you said your wife had noticed, you know, you're not looking good. But what were you feeling at the time? And you were like, okay, I'm not feeling great. Now she's saying I'm not looking great. How'd you make the connection?
I felt like I looked at myself in the mirror and said, yeah, it looks like I'm losing weight, I guess, now that you mention it. But other than that, I had just become accustomed to feeling however I was feeling, ironically.
We often do that kind of as we get older,
and I
right,
was just,
Doc?
you know.
Yeah, so I mean, very, not very unusual. Lymphoma doesn't always have, pain or any of the like alarming symptoms.
You don't have like a checklist necessarily to go down.
There's no clear checklist. Like, it can be really subtle. So something like what you described, really subtle. A lot of times other people might notice that you're not doing well. And especially for, men, I think, may not realize their symptoms. Somehow I feel like, it's your wife or your daughter or someone would be able to say that something's really wrong. You need to get checked out. So a typical story with that.
Certainly glad you did, Todd. And then you get this diagnosis, devastating. Let's go down the list of treatments that you went through, because the first line of treatment would be chemotherapy, and you had 18 weeks of treatment?
I believe that's right.
So then lymphoma returns. So Dr. Ahmed, how effective is chemo in treating Todd's type of lymphoma? In most cases.
Yeah, so the first line therapy, when it's newly diagnosed, even when it's stage 4, because you had bone marrow involvement and your blood counts were all off also. But even in that situation, we would expect it to be in the ballpark of around, I typically tell patients that out of 100 patients getting the R-CHOP, the first line therapy, probably 60 will not hear from this disease again, but 40 might. It's a ballpark. So overall, good odds of getting rid of this disease, but then there are still a fair number of patients that might have to deal with a relapse.
And that would have been Todd's case. So the lymphoma return, you then recommend CAR T cell therapy. I gave kind of a layman's explanation of what CAR T is, but how do you describe that, Dr. Ahmed, maybe to a patient like Todd who's never heard of it before? What exactly is going to happen?
So it's very interesting. So when Todd's disease came back, that was around the time that CAR T had just gotten approved to be in the second line for patients where it comes back really early or it doesn't go away with the first line therapy.
Because it used to be last line of defense.
It used to be third or fourth line, but now, that's when it was just approved as second line. So we were like, hey, Todd, this is the next thing that we would recommend. There's a survival benefit with this particular therapy. The ones that were approved was at that time like Yescarta, so that's what we were thinking about for Todd. It has a survival benefit, better than what we traditionally used to do, which was chemotherapy and then a autologous stem cell transplant. Again, a big word, but that's where we give high-dose chemotherapy and just do a stem cell rescue. So CAR T was better than what we were doing at that point for early relapse or just refractory cases, patients that had the disease come back really quick.
And explain again kind of what's happening with CAR T. You're actually taking for a patient like Todd, what's he having to go through?
Yep, so of what he went through, and he went through this twice. We took his cells. He's hooked onto a machine that kind of like, for some people who know what a dialysis machine looks like, it looks like that. If they don't, then it looks like a washing machine, right? So you're hooked onto it, and a circuit is created. So the blood is flowing to the machine, through the machine, and then back. So it's like a circuit. And the blood, and basically that machine just filters out the part that's rich in your body's, the soldier cells, the T cells, right? And the rest of the blood just goes back into the patient's body.
So you take them out, and then that's when they get sent off.
So then they get sent off to a lab, and in that lab, there's a whole, around a two-week process, at least minimum. It varies, the time varies, but around a 2-week process where those cells have to get genetically modified. So now they can see the cancer better. And in lymphomas, there's a certain protein on all the lymphoma cells. It's called CD19. So now these T cells, they can see the CD19 cells, so they can kind of identify the tumor, whereas before they couldn't. So in our body, our T cells, they rely on other cells to tell them that, hey, there's a tumor cell there, then they can go and fight it. Now they're independently able to identify those cells and go after them and just fight them once we infuse it back.
But not in this case, because Todd's cells were sent off, they were unable to be modified. So what happened, and why was this happening in Todd's case when we don't normally see that?
Yeah, so that's one of the things with CAR T. There's a whole bunch of processes, and like less than 1% of the time, it may vary from product to product, but really low rates. But it does happen, and here's where it did happen, right? Where there's a failure of manufacture, where the cells, they couldn't convert it into CAR T cells. It just wouldn't. There's many reasons for that. And we don't know exactly what reason really applied here, but they look and see how those cells are growing. Sometimes the cells don't grow enough. Sometimes they just don't take the genetically modified material, because it's sent through like a virus, a lentivirus, and that process doesn't work out. So because of a variety of reasons. And we know sometimes we know really early on in the process, sometimes we know after a few weeks. So in Todd's case, I think within a week or so,
It was
we
2
knew.
weeks,
Right,
10 days to 2 weeks.
Around 10 days, we were like, well, okay, it didn't go. You know, sometimes what happens is that patients who've just had chemotherapy, their cells, their soldier cells are already kind of low. So maybe that would be another reason, but really that wasn't Todd's case. And sometimes what happens is the lymphoma itself can also suppress, it has this environment where it can suppress the action or activity of the T cells, so that can also be the case. But at any rate, it didn't. So
And the odds were, we had numbers on it, 20% chance that it wouldn't, or 10% or something. And then the second time it was like maybe a 1% chance that it won't work, as I recall.
yeah,
And I remember,
I think the first time it was more like what I really quote as 1%. Like, okay, you know, it's gonna work.
right.
Most of the time it does, but then there's this 1% chance
Yeah.
that maybe it won't
So
manufacture.
Todd's kind of tricky.
It was
Well,
tricky.
he's a little
So
tricky.
So we tried it again. A lot of times it doesn't work the first time. The second time, you know, it does. But then it's super tricky.
Yeah, okay.
And then we were like, okay, there's something that either the tumor has affected the T cells or something's happened. We're not gonna go this route. We're not gonna do this again and again.
Right.
So plan A,
And that
out
was
the door.
like 4 weeks
Yeah.
worth of time.
Oh yeah.
At which point I was trying not to panic, of course, but the scans were showing were
The
lot
disease was
more.
growing.
Yeah, so you're
So, like 4 weeks
clocks are
we're waiting.
ticking.
Right.
Yeah.
Your
so
head's
I'm in a
spinning.
palliative state of mind.
Right,
But
right.
even when he's panicked, he doesn't show it.
I could tell. I could
Okay.
tell because you have chemo, plan A out the door. Now
Yeah.
CAR T, plan B out the door. You know, how were you mentally? Just how were you like? Okay, what's next, doc?
One of the cool things for me was the fact that Carl and I were very interested in science and whatnot, and enjoyed just learning about things. And my wife was brilliant at asking the questions and stuff. And still have chemo brain. I think what was I saying?
That's okay.
It's okay?
That's okay.
But it was a fascinating process. That's what I meant to say. And we were able to joke about it. I joked with my brother about, you know, how lucky can you be to be the 1%?
Yeah.
Right. Even though it's on the wrong end of it, the 1% failure on that CAR T stuff, and
Can we talk about the clinical trial?
we're fascinated to be a part of a clinical trial. Absolutely. And-
Well, yeah, you guys research and science, and here you are now onto that. You probably learned all about CAR T, had no idea
Well,
what
that's
that
what I'm
was.
saying. I
And
was
then
just
you-
catching up on
Yeah.
basically everything, you know, learning curve way behind we
Sure.
were, but fascinating catching up. And she said, well, we still have some options, which was great. Good news to hear about the clinical trial. And rather than feeling like a guinea pig in any way, I was already fully prepared for some time for things to you know, not work out necessarily. And so even had that happened, I was more than glad to participate in perhaps somebody else's help down the road.
Yeah, for sure, for sure. Well, and so let's talk
And
about
I got
that.
paid
And you got paid. I like
like
it.
$60
I like
a
it.
week
Hey,
or
that
something.
never hurts.
Oh,
That
something,
never
man.
hurts.
Yeah.
Let's talk about this clinical trial. Modifying Todd cells doesn't work. Then we talk about this study where we're talking about newer off-the-shelf version of CAR T. What is that? What do we mean by off-the-shelf?
Yeah, so Todd was enrolled in our CRISPR trial, which looks at off-the-shelf CAR T, which means that the CAR T is made from T cells that are not, we don't have to get it from his body, we don't have to modify his cells. We use a third party, so it's a healthy donor typically that has given their cells, and then you make like bunches of CAR T out of that. So it's readily available. That's the big advantage of those cells. So, and that's where really some of the, you know, the science is heading, because we have we have this great science with these CAR Ts, but then there are cases like this where we can't get our regular CAR T because of manufacture problems or other problems or what. So having an off-the-shelf option is you know, I think it's important, and down the run there are many pharmaceutical companies looking to develop different type of off-the-shelf CAR Ts. Basically, what happens there is that once you're enrolled in the trial, we skip the whole manufacture process. It just goes straight to getting the pre-CAR T chemotherapy and getting the CAR T, and that's it.
Todd, did it feel different this time around, getting these new cells from someone else?
Well, since I didn't really get cells before, I didn't have anything to compare it to, and as I recall, it didn't seem to feel bad or anything at all. I mean,
The process was the process.
we had like some, I think you called it mild, misnomer, mild chemotherapy for a couple sessions, but compared to what I'd been through before, that was kind of like a piece of cake. And then in the hospital, and up comes Tony and his crew with a sack of cells and put them in my arm. Had a catheter at this point, and I was in there, a week or so? Not more than a week.
We admit everyone for a week.
And it was like living in the hotel, with a wonderful help, and excuse me. It was uneventful, I thought.
Uneventful. That's uneventful is good. We like that.
It was pretty uneventful.
Yeah.
I mean, so we watch for side effects like that we would for any CAR T, the cytokine release, which is the fevers, or the neurotoxicity and all. But I think you cruised through it.
I think so. Yeah.
Well, we need to get to the good part, which is what finally put you into remission, right? So we're going to talk about that here in just a moment. But if you have any questions, you can use the chat on YouTube or Facebook. You can email the Medical News Network. That information is right there on your screen. So you're using someone else's cells. It did not put into remission, but it did get the lymphoma controlled enough that he could get the stem cell transplant. Is that correct?
After two times.
Yep.
2 times with that. Okay.
Yep. So he had a what we call a partial response.
Okay.
Which means that the disease melted like almost by half. So it didn't go away completely, but it melted almost by half, which is great because before that it was growing quite rapidly. And then we gave another infusion of that as well, a month apart, and he tolerated that fine. And we continued to maintain that response, which was just enough to get to the next step.
Which was the stem cell transplant.
Which was a stem
Get
cell
him healthy enough to do that. Where did you find your donor?
He lived in Florida, all the way down there, but we were related by our mother and our father.
Brother.
So my brother.
Brother stepped up. What was
Yeah.
that like, making that phone call, and what was that process like?
I think it was pretty simple. He as many times as I thanked him, he said, "Hey, you're the one that had to do the work." So it was to find out that it was 100% match. I think was very rare for that to occur. So he'd be the only person on the planet that would do that for me. And so I was glad he was around and healthy. And
Quite an experience, though, to have this big full circle moment, and it lands on your brother, and
Yeah.
here you are.
well, yeah, it's like a fairy tale, a book you would read, or
Right, the perfect
some
fairy tale, Todd.
made-for-TV movie. Yeah.
Right. Yes, made for TV movie. So this wipes out your immune system, as we know when you get these stem cell transplants. Right. So how long did you spend in the hospital? What was that recovery like?
It seemed like nearly a month,
Okay.
but when I look back at it, it was closer to maybe 3 weeks.
And your wife helped take care of your family, was
yeah.
surrounding you.
Yeah, oh yeah. And I was not ready to go home. I mean, the stem cell transplant, that knocked me out. And they thought I was okay to go home, and they were right, but I wanted to be back getting taken care of in the hospital for, I don't know, quite a while.
So just
The
trying
recovery
to get,
time, yeah.
right, wanting to feel better, but you also kind of had a bond with some of those folks. You were taking selfies with people,
yeah.
the care team.
I,
These became like what, family inside this hospital?
Yeah, from the beginning at the Cancer Care Center in Overland Park. I could start naming names, so I'd never stop. And then, well, Dr. McKittrick there, as the main doctor, and all the help. And then we came to BMT. Obviously, scary place, scary concepts. Not scary place.
Yeah, sure.
Not the doctors were scary.
Sure.
They were very inviting. It was strange to think, oh, what's this about? And we we felt very fortunate
Yeah.
to be able to have the help in the clinical trials and all that.
Yeah, you touched a lot of people in there, and
Oh,
you-
I'm sorry, I got off track again.
No, you're fine.
and
No.
that Tony, the
You're
fellow
good.
that helped with my cell stuff, he became like a counselor to me. I got
Yeah.
to see him so many times, 3 or 4 times, and then he was involved with my brothers getting his cells, and all the people on the floor were just so wonderful, and
and you wanted to document it
yeah,
with those selfies.
yeah.
What is life like in remission for you now?
Remission, I don't know if we use that word. I've noticed the word no signs of cancer a lot, or
No evidence of disease.
There is
Yeah.
no evidence of disease.
no evidence, and I like that.
Yes.
Yes.
Better than remission, because remission has the connotation of, okay, it
Okay,
might
when's
be
it coming back?
sitting
Yeah.
back there
Yeah.
somewhere. And whether truthfully or falsely, bad word, it's back there somewhere. I prefer to think of it as not.
Gone. Just no evidence. It's
And that way I know
non-existent.
I can move forward without that kind of fear in the background, which is pretty debilitating.
I bet. I
Too many
bet.
syllables.
So how is your outlook different day to day? You sound like you're a pretty happy-go-lucky guy, but how did this change you?
Man, that's. I'm definitely more mindful of the significance of every breath. Every waking moment of perceiving the world. That said, I'm feeling healed and better enough that I'm back in the ordinary, mundane world full of conflict and stress and these kinds of things. However, I've been able to adjust my attitude even in those situations, not always, but getting better at it, and trying to bring the mindfulness of the beauty of life and being here. And I definitely now live toward representing or advocating or doing something to honor the wonderful humanitarian process of history of science up to this point.
Yeah, you've been a big part of it now.
In that big
Yeah.
humanitarian human species sense, but also just as somebody that maybe 1 out of 10, 1 out of 100, 1 out of 2, whatever it may be, I'm here, and I owe it back to the world to honor
Yeah.
all those.
Serve the purpose
Yeah.
of going through all that you've gone through. And Dr. Ahmed Todd now in the survivorship
Yes,
phase, which
yeah.
is what that's the phase we want everyone to get to. What does that look like for him? What are checkups like? What's the surveillance going to look like moving forward?
So it's now so everyone's different, right? Depending on what complications they might have or side effects, or for after an allo transplant, because that's a pretty that's an intense therapy. And he's as he said, as you mentioned, the first couple of months are a lot of visits, like maybe 2-3 times a week, and then it slowly tapers out. But for Todd, like, you've not had any major issues really after the other medication side effects, but otherwise,
Yeah.
things we worry about like infections or graft versus host disease. I mean, we've not really had anything. We're always here if you need anything, but otherwise we sort of now at every 2-monthly visit, like, scheduled, and we can even like move that out depending on how things are going.
Sure.
So survivorship is now for you like just taking care of your regular health, right?
Mhm.
Being active, going to your primary care doctor, all the regular risk assessments. So it's just the regular stuff that everyone has to do.
That's good. Good to
Yep.
hear. I want to get to some questions from our viewers this morning. And Lori wants to know, would this help if you are IgA deficient?
So CAR T itself right now, for the treatment of IgA deficiency, So for the so if it's for the treatment of IgA deficiency,
And what is IgA
Yeah.
deficiency? What is that, so people know?
That's like an immunodeficiency, and that can be associated with some autoimmune diseases. So CAR T is being studied in autoimmune diseases. That's a new frontier for CAR T, actually. The same CD19 directed CAR Ts, where we're having a whole wave of clinical trials in several different immune mediated diseases that are non-cancer. If the question was whether CAR T would work if there is IgA deficiency, I believe that it still would, but really there would have to be more specifics of the case.
Sean wants to know, will CAR T become the first line of defense to treat lymphoma? We said the second in this case. When will it be first?
There are trials also studying CAR T in first line. So we have a trial here at KU that's looking at CAR T in high risk diffuse large B-cell lymphoma first line, like after they're diagnosed, if they have some high-risk features, they should be referred for a clinical trial. We have actually 2 clinical trials in that space right now.
Becca wants to know, where can I donate my cells? We donate blood, we do all sorts of things. Where do you go to donate these cells to be put on the shelf?
So right now, those are specifically, there's no place to donate cells, but pharma companies themselves, they have to identify their certain individuals. So usually, so this is not really open to the public right now.
Gotcha. Okay,
I guess.
But thank you for clarifying that, because when we think go donate your cells, then that's something great. I'm in line. Let me go do that. So, question from Jeremy: can CAR T cell therapy be used for things like viruses or infections, maybe even as a way to beat or bypass antibiotic resistance?
Good question.
That's a very good question. There are some studies of CAR T or T-cell mediated therapies, like T-cell directed therapies. Like for example, we had trials in our post-allo patients in which we had T cells that were directed against certain viruses. So not exactly CAR T, although there can be CAR Ts that might be in development for some of these infectious disease. But we have T cells that are taught how to go against a certain infection, and they are used, are being studied. None of them are approved, but there's many studies ongoing in that space.
Jill wants to know, is CAR T available everywhere? Do all patients with this kind of cancer have the opportunity to get it?
A very, very good question. So CAR T is available commercially, like approved by the FDA for 2 particular, there's for non-Hodgkin's lymphoma, which Todd had a type of that, and for multiple myeloma. It's available at academic centers, so it's restricted to to some of the larger centers. So not every office will be able to offer CAR T, but they can certainly refer for CAR T. We can go into a whole conversation about, it can be more available in some states, less available in some states, but I mean, that's the general concept.
But it is available here.
It is definitely available here, and everyone who has multiple myeloma or non-Hodgkin's lymphoma
can ask to be referred here.
Yep, early on should be asked to be referred here to find out what the trials are and find out are they eligible for it.
What's the big takeaway from our conversation today?
So our big takeaway, and the really cool part of this whole story, was how this clinical trial completely changed the course of Todd's disease, right? We had a lymphoma that was a raging lymphoma, hard to control, and then the actual CAR T manufacturer, which is supposed to be one of the best therapies out there, was not an option. And this clinical trial changed the course of the disease to where we were able to get him a more definitive therapy. So I'm just thankful for that. That's my take home here.
Todd, you were able to get to your daughter's wedding, is that correct?
That's right.
After all of this was over?
After all of that, yeah.
That must have been a big goal to get you there.
Well, yeah, it was, I mean,
hello.
Yeah.
Picture perfect,
right.
walking her down the aisle.
Yeah, I would have missed that were it not for about 100 different kinds of lucky factors, I guess.
And here you are. Well, thank you so much for sharing your story.
Thank
What do
you.
if someone's listening, what do you want them to take away from your story?
My story, I don't know. I'd like to tell them to have courage and faith if you're going through things, and try your best to find out where your clinical trials are. I don't know that I would have come across this one had I not been here and somebody told me about it. But knowing that now, I'll know to research in the future for clinical trials all over the country, whatever. Just, I mean, that's so amazing that you might feel like you have no hope, but there might be somewhere, a little place in the universe where they've got something that might work for you.
Yeah, your story revealed that there are more than one option, more than two options.
Yeah, and even right in the nick of time.
Yeah.
So as I recall, that clinical trial just became available such that it was there for me. So
Well, we're so glad. Such a pleasure to have you on the show today.
Oh, it's a pleasure to be here.
Yes, yes. Come see us anytime, Dr. Ahmed. Always good to see you.
Thank you.
Thank you so much. Thanks to all of our viewers for being with us today. We'll see you back here on Wednesday. Coming up Wednesday on Open Mics with Dr. Stites. When elite athletes are neck and neck, sports psychology can give them an edge. I'm Jessica Lovell on the next Open Mics with Dr. Stites. We meet a champion sprinter who knew the importance of therapy and finally found the therapist who understands what athletes face. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.